Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Prabhudev Prasad Puddappa from Boston, Massachusetts. After completing his post-graduation in PG at Chandigarh, Dr. Puddappa pursued fellowships in the Massachusetts General Hospital, Boston, an adult reconstruction fellowship at the University of Minnesota, Minneapolis, and a fellowship in sports medicine at the Trier Orthopedic Center. He currently serves as assistant professor at the Boston University School of Medicine and attending orthopedic surgeon at the VA Boston Healthcare System, Boston. He's the editor of Archives of Orthopedics Journal and also serves as peer reviewer for several higher impact journals. He has published extensively across several top orthopedic journals and also has several high impact publications to his credit. So today it's my great honor to introduce you to Dr. Prabhudev Prasad Puddappa from Boston, United States. Over to you, Prabhu.
All right, thank you, Dr. Hitesh. Thank you for this opportunity, and it's a pleasure to contribute to the orthopedic principles. Today, I'll be talking about intraoperative fractures in primary total knee arthroplasty. So I'm going to be presenting this more of as a literature review. So this is a rare complication. Again, we are talking about intraoperative fractures in primary knee arthroplasty. So it is a rare complication. The incidence has been reported to be somewhere from 0.2% to 4.4%. It was actually one study which reported that higher incidence. Lombardi and his colleagues, they had an incidence of about 4.4%, but a large majority of the authors have reported under 1%. So it is a pretty less common rare complication, we can say. But this can be actually underestimated because some of the clinically insignificant fractures may be missed, both intraoperatively and postoperatively. Many authors have reported that females have a significantly higher risk, and a male to female ratio of somewhere from 0.34 to 1 has been reported by many authors. The mean age of the patients in the reported studies was about 60 years, with a range of um, 45 to 73 years. The most common indication for total knee was found to be primary osteoarthritis, from somewhere about 57 to 87% of the population. Rheumatoid arthritis was the second most common indication. So what are the risk factors for the intraoperative fractures? Let's look at the patient factors first. And of course, the most important one being the osteoporosis. Mack and his colleagues, they found that almost two-thirds of the patients had at least one strong risk factor for osteoporosis. Rheumatoid arthritis is another significant risk factor, again, because of the patients being on multiple medications and also higher incidence of osteoporosis. Advanced age, again, because of the higher incidence of osteoporosis. And as I mentioned previously, females have higher risk because postmenopausal women have a higher prevalence of osteoporosis. And anatomically, they have a smaller average-sized femoral dimension as compared to men, so they are at higher risk. Again, chronic steroid use for multiple indications and other metabolic bone diseases are also important risk factors. Patients with severe varus and valgus deformities, which require a semi-constrained type of implants, they are also at a higher risk. And patients with severe stiff knees, preoperatively with a range of motion of under 90 degrees, they are also at a higher risk of the intraoperative fractures. Are there any risk associated with particular implants and instruments? And yes, many authors have shown that posterior stabilized knee arthroplasty has been found to be associated with higher risk of intraoperative fractures, and we'll talk about that more in the next few slides. Constrained implants also are at higher risk. Pin track positioning during computer navigation assisted total knee arthroplasty, it has also been shown by authors to be a higher risk because these pin tracks could be large size, and they can act as stress risers, thereby inducing an intraoperative fracture. Technical factors like inadequate or excessive or eccentric box cut in a PS knee and a tight fitting trial or final component anteroposteriorly can also be an important risk. Angular insertion or removal of the trial and the final implants is a risk factor. And of course, excessive hammering force while placing the trial components or while placing the final component can produce an intraoperative fracture. Now, when we looked at the classification, there is no dedicated classification for the intraoperative fractures, but most of the authors typically classify the femoral fractures into diaphyseal fractures and metaphyseal fractures. Diaphyseal fractures are typically an anterior or anterolateral cortical penetration, usually secondary to a malpositioned intermedullary guide, and many times these are undetected intraoperatively. And of course, this is it can happen more frequently in patients with poor bone quality, and many times they might be seen only on postoperative X-rays. Metaphyseal fractures, they can be grouped into intercondylar splits, like shown in this picture. Typically, it's a fracture extending towards the diaphysis without communicating into the cortices, and typically these are stable fractures. But they can be complete fractures involving either the medial or the lateral femoral condyle. And supracondylar fractures and epicondylar fractures are pretty uncommon. Again, in tibia fractures also, there is no dedicated classification. We found for the intraoperative fractures only, but this Mayo fracture classification of periprosthetic tibia fractures, it includes both the intra and postoperative fractures. They classify this into 4 types based on the anatomic location. Type 1 is a fracture which involves the tibial plateau, involving the prosthesis bone interface. Type 2 fractures, they are adjacent to the tibial stem in the proximal metaphyseal diaphyseal region. And type 3 are distal to the tibial prosthesis. And type 4 fractures, they involve the tibial tubercle. And each types are then further subclassified into type A, B, C. A and B are postoperative fractures. We're not talking about them today. And type C are the intraoperative fractures. So for intraoperative tibial fractures, we have type 1, type 1C, 2C, 3C, and 4C. We can classify them as. Like I mentioned in the previous slide, certain implants are associated with higher risk of intraoperative fractures. And as I mentioned earlier, posterior stabilized total knee has been demonstrated by many authors. The relative risk of femoral fracture in posterior stabilized knee was found to be 4.74 as compared to the CR knee by Alden in his large series of intraoperative fractures. Delasot and his colleagues demonstrated that intraoperative fracture rates were 0.3%, 0%, and 3.13% in PS, CR, and semi-constrained implants, respectively. And intraoperative fractures were found to be almost 10 times more likely to occur with semi-constrained implants when compared to the PS implant. Incidence of tibial fractures was higher with the use of smaller tibial components in one of the studies. Some authors have tried to evaluate the amount of bone resected from the intercondylar notch and compare them among the different designs available in the market. And this particular study has and his colleagues have found that there is a significant variation in the amount of bone that is resected from the notch in PS knee designs. And they found that Some designs, the amount of bone resected is significantly smaller as compared to the other designs available. So in this particular study, they found that Genesis and OptiTrack were found to have found to remove less amount of bone as compared to the other designs. In a similar study, in Delhi and his colleagues, they again tried to compare the amount of bone resected from the intercontinental notch region among these three designs available in the market, and they tried to compare among three different sizes, like the small, medium, large sizes of the PS knees. And they demonstrated that as the size of the femoral implant decreases, the amount of intercondylar bone resected also decreases significantly in some designs as compared to the others. In this particular study, again, they showed that the Persona design was found to have the least amount of bone removed. And as the size of the femoral implant decreased, the amount of bone resected also decreased significantly. So when do these fractures occur during surgery? So of course they can happen anytime, but let's look at the literature here. Alden and his colleagues, they found that a large majority of the femur fractures, about 40% of them, occurred during surgical exposure and bone preparation. About 33% occurred during trialing of the components, and about 19% occurred during final cementation. In the PS knees, again, during preparation of the intercondylar notch while removing the bone is when there is a higher risk, and also while impaction of the trial and the final component is at a higher risk during the PS knees. The tibial fractures, large majority of the tibial fractures, they occurred while preparation of the tibial keel and during impaction of the final component. Overzealous hammering of the final tibial component, especially with the packing of a lot of cement into the tibial canal, has been recognized to be a strong risk factor for intraoperative tibial fractures. So location and characteristics. So which part of the bone they involve. Most of the studies we looked at, they showed that femoral fractures were more common than the tibial fractures, but in some studies they had more tibial fractures. But when we look at the total overall picture, femur fractures were more common in general. In the femur, medial femur condyle was the most common fracture site, followed by the lateral femur condyle. In one of the study, the intercondylar split fractures were found to be more common. Again, supracondylar fractures and fractures involving the epicondyles were significantly less. In the tibia, large majority of the reported tibial fractures involved one of the cortices, either the anterior, posterior, medial, or lateral cortex of the tibia, and most of them were without a significant displacement, but they can involve the entire tibial plateau. And again, complex fractures involving the metaphyseal, diaphyseal region and tibial tuberosity were pretty rare. So what management options do we have? There is no consensus in the literature on a particular type of treatment plan for a particular type of fracture, but the general rule is fracture fixation and arthroplasty principles should be followed to achieve a stable internal fixation, and any unstable fracture site should be bypassed with using an intermedullary stem. Like I have listed here, there are many type of fixations have been utilized, including screw fixation, sutures, figure of 8 word technique, intermedullary stem components, plated screws, constrained knees, and distal femur replacement if needed, and various combinations of these depending on the fracture type. The femur fractures, when we look at the femur fractures, non-displaced intercondylar fractures like this, they are typically stable. And Lombardi in their study, they they did not recommend any further intervention for this, and they treated these fractures with no changes in their postoperative protocol. They let them full weight bear and without any restriction in the range of motion. In non-displaced fractures involving the femur condyles, involving either the medial or the lateral femur condyle, which extend into one of the respective cortices, they can be treated with partially threaded cancellous screws, achieving a stable fixation, and with a standard femoral component. If the fracture is displaced, involving either the medial or the lateral femoral condyle, then they are unstable. So they are better treated with plate and screw fixation like this, or they can be treated with screw fixation with a stemmed femoral component. If the fractures are highly comminuted, involving the entire condyle of the femur, or if there is a comminuted supracondylar fracture, then we had to consider a distal femoral replacement. In tibia fractures, again, as I mentioned, the large majority of them were small vertical crack fractures involving the cortices. If they don't extend if they don't involve the entire plateau, then they can be treated with a standard tibial implant with a compression screw if needed. But if there is more of a fracture involving the entire tibial plateau, they are unstable, and like the Mayo type 1C fracture, and they are better treated with using a stemmed tibial component like this and a compression screw if needed to achieve a better stable fixation of the fracture. If the fracture involves the metaphyseal diaphyseal region, then we have to use a stemmed tibial component with or without a plate. If the fracture is far away from the standard tibial implant, then they can be treated with internal fixation alone. Most authors have demonstrated that if they're treated well, they do well clinically. Pinaroli and his colleagues demonstrated that there was no statistically significant difference in the outcomes in comparison to the series of patients without complications. And many others also have shown that have also reported high rate of radiographic healing of these fractures, of course, except some of the rare complex fractures. How do we prevent these fractures? Preoperative planning is very important. Thorough medical history, careful evaluation of the bone stock and bone mineral density is very important. Evaluation by a medical specialist should be considered for appropriate pharmacological treatment if needed. Complete up-to-date imaging studies should be available. And patients with high risk of intraoperative fractures, we should have a backup of revision components with intermittent stems, augments, plate and screws. In female patients, one should consider a CR knee design or an ultracongruent polyethylene insert instead of a posterior stabilized knee design. During surgical exposure, it's very important to get a generous exposure rather than struggling with a small approach or small exposure. And one should try to free the medial and lateral gutters before forcibly flexing the knee. And again, patients with severe deformities, appropriate medial and lateral releases should be done before trying to forcibly flexing the knee and trying to dislocate the tibia forward. Any mismatch between the intercondylar resection and placement of the trial and the final components should be avoided. Femoral component should be appropriately lateralized to decrease the risk of the medial femoral condylar fracture. Varus or valgus malalignment during insertion and extraction of the femoral component again should be avoided. Appropriate tibia releases should be done to get a good exposure before dislocating the tibia forward with excessive force, um, or stuffing of the tibia component with cement, and overzealous hammering during final seating should be avoided to prevent these fractures. So the take-home points are the intraoperative fractures during primary knee arthroplasty are rare, and they are associated with, and there is higher risk associated with the patients with poor bone quality like osteoporosis, rheumatoid arthritis, advanced age, female patients, and those with severe deformities and post-destabilized knees. Careful preoperative planning is very important with a thorough history, evaluating the bone stock, and availability of appropriate instruments and implants in high-risk patients. Um, Appropriate exposure is with appropriate surgical releases should be done. Careful bone preparation and also careful trialing and fine implant placement in high-risk patients, and standard principles of fracture fixation and standard arthroplasty principles should be followed to achieve a stable interfixation, and any unstable fracture site should be bypassed with utilization of stemmed components. And literature has shown that a satisfactory radiographic and functional outcome can be expected with appropriate treatment of these fractures. Thank you.
Thank you, Prabhu, for that very comprehensive presentation. Just a few questions.
Sure.
What do you think is the problem with knotting? Do you think that knotting is a risk factor? Because of late, there are a few publications that say that notching is not a big risk factor for a periprosthetic fracture. What is your take on that?
Yes, that's definitely a good question. There have been many studies in the past and looking at the notching and its risk factor associated. Some authors have demonstrated that it can be, especially the post-operative periprosthetic fractures, is an important risk factor. But some of the recent studies have shown that it probably may not be. I would definitely try to be careful not to notch, because even though we don't, it's the literature, there is no consensus, but I would say it can be an important risk, especially in patients with poor bone quality. So it is something which we should look at and try to avoid it, I would say.
Thank you, Prabhu, for that. The other question is with similar relationship as a periprosthetic fracture, suppose the fracture goes through the cement mantle and it becomes unstable. So do you think that revising the entire system should be followed intraoperatively?
Intraoperatively, yeah. So if that, so this, intraoperatively, when when you put the cement on and you start hammering the component, if you recognize a fracture at that time, then what I would do is quickly, take the implant out and try to take the cement out before before the cement sets in. I think that should be, I think one should do that if we see the fracture right away. But if we miss it, and if all the, if you put the implant in, get the knee straight, and then we're waiting for the cement to settle down, and if we recognize a fracture at that time, and that's a problem. Then, and if it is again, it depends on the fracture type. If it is an unstable fracture, then we probably have to consider revising it, which again is pretty unlikely, but we have it in front of us, and if it is better to recognize them when we are putting the implant itself.
Okay, because as you said in one of the slides, that if it is a distal femur fracture, you may have to even think about a distal femur replacement, isn't it?
That's right. Yeah. So when I was reviewing the literature, there are a couple, not very common, like a couple of reports which have shown that which surgeons they were doing it. They unfortunately had a very comminuted fracture involving the entire femur conda, and they had done their bone cuts, and they didn't have the backup available. Then what do you do? Because a large majority of the center, like if you are working in a very large center with high volume, they probably have everything on the shelf. Then, okay, let's bring it in and then let's do the revision. But most places don't have the backup of revision implants. If unfortunately if that happens, then if you are already done the cuts, then we had to we had to close the wound and place just an external stabilizer until we take the patient back to revision.
Thank you,
Yeah.
Prabhu, for that. The other very common scenario that I would want to discuss is in extreme osteoporosis, what really happens is the bone, instead of fracturing, it just gets compressed and just goes inside.
Yeah.
And
Yeah.
how do you deal with such a scenario? Not a fracture, just it just compresses because of the severe osteopenia, and there's
Uh-huh.
a huge defect. And how did you address it?
Yeah, that's a very difficult situation. So, if you are, one is preoperative planning. If you are, and if the patient is high risk, and if you when you look at the X-rays, it looks like, well, yeah, this bone quality really looks bad. Then I would have the backup available. So I would ask the rep to bring in, hey, we might need a stem, we might need intramedullary stem, we might need augments. So that would be a good plan. If some many times that may not happen. So if it happens intraoperatively, then there is no other option. We have to try to fill it up with cement as much as we can. And typically for the tibia, I usually have a small stubby stem available most of the time, and then I will just use that extra stubby stem to make it more stable.
Thank you, Prabhu, for that. Just one last question before
Sure.
we wind up.
Uh-huh.
What do you think is the role for a teriparatide in extreme osteoporosis? Just prior to surgery, give teriparatide. Do you think that building a bone will reduce the risk of fractures?
There is no good evidence in the literature for this, but that is something which can be considered. But the problem with that is, it's a long-term treatment, right? For to improve the bone density, the recommended treatment is, close to like a year or 2 years. But that is something which should be considered, because if we are dealing with an intraoperative fracture, which is more, it is definitely a devastating problem, especially if it ends up being a more complex type of fracture. So it's better to, have prep the patient to decrease the risk preoperatively, and definitely teriparatide can help with that.
Thank you, Prabhu. I think that's all the questions that we have. Thank you for joining in. Fantastic lecture, a lot of insight, and you've gone extensively to all the available literature. It has been a very great pleasure to have you on board. Thank you very much for joining in.
Thank you so much, Hitesh. It was nice. It was my pleasure to contribute to orthopedic principles. Yeah, look forward to contribute further. Thank you.
Thank you. Bye bye.